Good evening, welcome. I'm Steve Beattie, I'm a member of the Sunnybrook board, and I'd like to extend a warm welcome to all of you tonight. Tonight we're going to talk about something near and dear to all of us, our hearts, and we're going to talk about Sunnybrook's Schulich heart program, and it's made up of a team of expert cardiac surgeons, cardiologists, vascular surgeons, cardiac anesthetists who work together with some of the most innovative ways to treat heart and damaged blood vessels. The team has performed many Canadian firsts and have found strategies to meet the needs of an aging, complex heart patient. Their minimally invasive procedures mean many shorter hospital stays, less pain, and an earlier return to normal activities. Tonight, we're truly fortunate to have some of those experts with us to discuss a number of heart-healthy topics. We hope you find these talks to be meaningful, and if you're not on our speakers series list, our mailing list, please sign up today. You can sign up just outside so that we can keep you posted and in the loop about all our upcoming events and their timing. Now, without further delay, I'd like to introduce tonight's moderator, Dr. Bradley Strauss. Dr. Strauss is the chief of the Schulich Heart Program. He is an interventional cardiologist with specific interest in coronary chronic total occlusions and developing novel cardiac devices and therapies. He's also interested in the commercialization of coronary innovations. Dr. Strauss is a founder of Inventions innovation program here at Sunnybrook Health Sciences Center. Dr. Strauss has been instrumental in organizing tonight's event, and we're very glad to have him here again to guide us through the evening. And we're also glad those online can watch us as well. Please welcome Dr. Strauss.
Since I know everyone knows who I am because it actually says it right there. So anyway, good evening everyone, and thank you again for joining us for the Schulich Heart Team's annual public lecture series. We appreciate everyone coming. I know many of you come year after year, and I'm sure you'll find tonight's lectures and presentations extremely interesting and very interesting to follow. So thank you for coming. A few notes before we start. Just so you know, there's no break during the evening. If you need to use a washroom, it's just outside there. There's also a place for refreshments located in the foyer. If you have questions, we'd appreciate it if you'd save them until the end of the evening. We have a group of people who are circulating with white cards, and you can write your question on there either now or after ending one of the speakers. And at the end of the evening, we'll try and bring all the questions back with the panel that will be able to give you some excellent answers. And for those outside looking on the webcasting, we wish you a good evening as well. Thank you for joining us. So we have three amazing speakers tonight, and they're all touching on something completely different. So you'll get a real potpourri of what we do in vascular disease and cardiovascular disease. So our first speaker tonight is Dr. Stephanie Poon. And Stephanie's been with us. She's relatively new, about 2 years now that she's completed, or almost 3 years. And she has brought a skill set in how to look after patients with heart failure. It used to be heart failure was a disease that we didn't have many therapies about. None of us really wanted to look after the patients because it was so difficult to do it. But it has become an incredibly technologically advanced and medically, in terms of the medications, very advanced field of cardiology, such that we now need an expert in it to guide the rest of us who do cardiology to look after these patients. And Stephanie is that individual. She leads our heart failure clinic and our heart failure team here. And you will see that she has a lot of energy, a lot of enthusiasm, and will have you look at heart failure in a way that you never did before. So we're very fortunate that Stephanie is going to speak with us tonight. So please welcome Stephanie.
Well, thank you very much for that wonderful introduction, Brad. I think I turned off some lights here by mistake. Okay, so I was told that that would work if I just clicked on it. So it is definitely a pleasure to be back here again. Tonight, I'm going to be talking to you about heart failure and take you through some of the many options that we have to treat heart failure today. So we're first going to go through the basics, and we'll work ourselves up gradually to the more advanced therapies. But before I begin, I kind of like to take a poll of the audience and ask, how many people in here actually have heart failure or know someone who has heart failure? Just raise up your hands. Holy crow, okay. So that's more than half of you, but honestly, that's not much of a surprise, because as these 2016 statistics from the Heart and Stroke Foundation demonstrate, heart failure is the most rapidly rising cardiovascular disease. Currently, 600,000 Canadians have heart failure, and every year, 50,000 new people are added to that list. So it is a condition that carries a very high morbidity and mortality, so a heavy cost to the patient and to our healthcare system in general. So the one-year mortality for heart failure patients is about 25%, and the median life expectancy for someone diagnosed with heart failure is approximately 5 years. It is the second highest cause of readmissions for anyone over the age of 65, and if you have been admitted to hospital with heart failure, there is a 21% chance that you will come back to hospital again. Overall, the cost of heart failure to our healthcare system is about $2.8 billion per year. So this figure here illustrates the number of heart failure hospitalizations in Canada projected out to the year 2025. Since 1980, the number of heart failure hospitalizations has been increasing steadily, and this trajectory is expected to continue upwards. Similarly, the number of heart rate deaths in Canada is expected to rise dramatically for both men and women. So what exactly is heart failure? This is one of the questions that I love to ask my patients on their first visit to the heart function clinic. And usually the answer that I get goes something along the lines of, well, I think it's when the heart stops beating. And that's a common misconception. But in actuality, heart failure is better defined as a gradual decline in the heart's ability to pump and circulate blood. And this occurs when the heart muscle becomes damaged for some reason. Here's a list of some of the more common causes of heart failure or that can damage the heart. So it's by no means a comprehensive list, but I just wanted to give you a feel for some of the more common causes of heart failure. And in North America, the #1 cause of heart failure is actually coronary artery disease or heart attacks. So there are two different types of heart failure which are illustrated on this figure here. On this side, we have people with systolic heart failure, in which people's hearts become dilated and weak, and really the hearts don't pump blood properly anymore. So simply put, systolic heart failure represents people with weak hearts. It is otherwise known as heart failure with reduced ejection fraction, or HFrEF for short. On the other side, we have people with diastolic heart failure who have normal pump function in that their hearts are strong, but they are also very stiff, so their hearts have trouble relaxing. And in this case, it impairs the ability of the left ventricle to fill with blood, thus causing blood to go backwards, causing congestion in the lungs and shortness of breath. So tonight for this talk, we will focus mainly on systolic heart failure, or heart failure with reduced ejection fraction. So regardless of whether you have diastolic or systolic heart failure, the symptoms are fairly similar. So if you have a trouble pumping blood forward to the rest of your body, you're kind of going to feel tired and a little bit run down. If the blood starts backing up into places where it shouldn't, where the heart is connected to, for example, your lungs, you might cough and feel short of breath. As well, if the fluid backs up into the veins in your entire body, you may notice some swelling in your abdomen, legs, and feet. So people with heart failure feel short of breath and swollen all over. So how do we treat heart failure? Well, I'm going to take you through some oldies and goodies. That's the standard treatment that we have. And as well, I'm going to tell you about some of the newer kids on the block, about the therapies that have just come down the pipeline recently. But before I do that, I want you to understand how these drugs work. So in order to do that, I kind of need to take you back to your high school physiology days. Does anyone remember those days anymore? And the word homeostasis, yeah? So homeostasis is just a fancy word for balance, because our bodies love balance. So whenever a system in our body isn't working so well, our bodies upregulate another system as a compensatory mechanism. And in the world of heart failure, it's the renin-angiotensin system that's upregulated to compensate for your heart failure. Now, some of you may ask, okay, well, what's the big deal about that? I want you to take a closer look at the downstream effects of the system. Notice here, salt and water retention. Also, it causes your blood vessels to constrict and gives you higher blood pressure. Additionally, the downstream effects result in cardiac remodeling, which is just a fancy way of saying that your hearts actually change shape, become thicker, bigger. These are not good things. So if you were a drug company that was interested in heart failure, you wanted to manufacture some super miracle pill, you would come up with some medications that would block the system, right? So in the world of heart failure, we have 4 different classes of drugs. First, we have the diuretics or the water pills, and the most common one that we use is Lasix, otherwise known as furosemide. Then we have the beta blockers, and these guys help to slow the heart rate down and reduce the workload of the heart, and they also help to make the heart a little bit stronger. These are medications that end in OL, like metoprolol, bisoprolol, carvedilol. Okay? Then we have ACE inhibitors, which dilate the blood vessels. These drugs end with IL, like ramipril, perindopril, enalapril, chendolapil, right? If you are intolerant to these medications, and the most common reason is because you develop a dry cough to them, then we can replace this class of medications with the angiotensin receptor blockers. And finally, the aldosterone antagonists help to reduce water and salt retention. And these drugs are things like spironolactone and eplerenone. Okay, so this figure just shows you where in the renin-angiotensin pathway the drugs operate. So they block various areas of this pathway. So this is where the diuretics work. Here is where the beta blockers have effect. These are the ACE inhibitors. And finally, the aldosterone antagonists. So they're all targeted against this renin-angiotensin system pathway. So the water pills or diuretics like the Lasix will make you feel better because it'll help you to eliminate some of the extra fluid in your body, make you breathe a little easier, you'll be a little less swollen. But the other drugs, like the beta blockers and the other 2 that I'll go over, actually have some additional benefits. So this figure, drawn from a clinical trial called the MERIT-HF trial, shows that people on metoprolol compared with placebo actually had lower mortality, okay? And also we have a figure from the Copernicus trial that used carvedilol, and it shows that people on the carvedilol had a better chance of an event-free survival, meaning that they had less hospitalizations and less death, okay? So excellent drugs. Now this figure also demonstrates that beta blockers can help improve your ejection fraction. So on the y-axis here, you have LV ejection fraction, which is just a way that we quantitate how strong a heart is. So normal hearts pump out or eject about 52% of the blood is put into them. Hence, normal ejection fraction is about 52%. So in this figure, people have very weak hearts. You can see that, you know, the ones on standard therapy have an ejection fraction of about 25%. And when you add in the beta blocker, look at that. You can actually see an increase in LV ejection fraction of about 10% in general, so that the hearts at the 3 months' time are much stronger if they're on metoprolol. Now there are a whole slew of trials like Consensus, Solve, Save, AIR, and Trace that demonstrate ACE inhibitors help make you live longer. So this figure summarizes the data from all of those trials. As you can see, you aren't going to be published in a cardiology journal unless you have a snappy acronym, right? Okay, so then here's a Rails trial for the aldosterone antagonists, and they also help to improve survival. So you see the solid line here is the people on spironolactone, and they reduce heart failure hospitalizations as well. So the messaging is all the same, and that is why when you are first diagnosed with a weak heart, we have to start you on these 3 different classes of medications. What we do is we start low and we go slow with increasing these doses. And that's because obviously medications have side effects. So some of them will lower your blood pressure, and beta blockers will also slow down your heart rate. The goal ultimately though is to increase these medications so that we reach the doses used in the clinical trials. Even if you tell me you're feeling well, I'm going to increase your medications. Now, why would I go about doing that? because the benefits of these drugs are actually dose dependent. So this figure here shows, the LV ejection fraction, which is a measure of how strong your heart is. And it shows people who've been put on low to high doses of carvedilol. Sorry, apparently I flail my arms too much when I talk. So as you can see, everyone who is on carvedilol experiences an increase in their heart pumping function, yes? But it is only the people on the highest doses, represented by this bar here in the red, that demonstrate the biggest improvement. So that is why we always try and maximize your medications so that you will get the biggest bang for your buck.
Code blue, C Charlie 3, lab 3. Attention please, attention, please. Code blue, C Charlie 3, lab 3, and a message.
So both Dr. Cohen and I are actually on call tonight, but hopefully the residents will be able to take care of that. If my phone rings, then we know why. So these are the guidelines from the 2017 Canadian Cardiovascular Society, and it basically summarizes everything that I just said. So if you are a person who has a weak heart, so an LV ejection fraction less than 40% and symptoms, we want you to be what's called triple therapy for heart failure. And those are the medications I just told you about. ACE inhibitors, beta blockers, aldosterone antagonists, yes? And if you have NYHA class 1 symptoms, which simply means you're feeling fantastic, then we don't have to change anything. However, if you are limited in your activities by breathing, this is where we think about adding in some of the newer therapies that have come down the pipeline shortly in the world of heart failure. So what am I talking about? Well, remember this figure that I showed you about the neurohormonal imbalance that was present in heart failure and how it was a renin-angiotensin system that was upregulated, and most of our medications there block that pathway? Well, one of the newer medications came out where not only does it block that bad renin-angiotensin system pathway, but it also upregulates or promotes the good pathway, which is the natriuretic peptide pathway shown in the green here. So this new drug I'm talking about is called sacubitril valsartan, or the other easier name for it is Entresto. Okay? So Entresto was actually studied in a massive trial published in 2014 in the New England Journal of Medicine that involved 8,442 patients who were limited in their activities by breathing, and they had weak hearts, and they were randomized or given either the new drug, sacubitril valsartan, or enalapril. If you will remember from earlier, this is one of our ACE inhibitors, one of our oldies and goodies standard therapies, right? And this is the exciting part. Up until now, nothing had ever beat the ACE inhibitors. So when this trial came out, there wasn't much hope that it was going to have any difference compared to its predecessors. But this is why we were so excited in the heart failure world when the results came out. So when they looked at first hospitalization for heart failure, they found that the people on the new drug, represented by the line in green, had less hospitalizations. And for those statistics buffs in the audience, I don't know if you guys know anything about p-values, but this is a statistical difference, all right? So it's statistically significant, not just mere coincidence. And additionally, it actually helped to decrease all-cause mortality or death from any cause. And that essentially is the holy grail for any medication, right? So it made you live longer when compared to enalapril. So that's why we were so excited about this. This was huge news. So huge, in fact, that when this trial broke out in 2014, we included it in our heart failure guidelines for that same year, even though we didn't even have access to the drug at the time. But fortunately, now we do. So this next medication that I have is based on the premise that your resting heart rate is directly related to mortality in patients with heart failure. So in other words, if you have a higher heart rate, you will have a higher mortality as well. So one of the things that we try to do with our medical therapies is we want to decrease your heart rate because that improves your mortality. So most doctors or clinicians will target a resting heart rate between 50 to 60 beats per minute, or as low as tolerated. So this is where ivabradine comes in. So ivabradine is a new medication that slows down heart rate above and beyond what beta blockers can achieve. And it actually works on the funny channel in the sinus node. I'm actually not making that up. That is a real name for that sodium channel. It's a funny channel. And it's located in the sinus node, which is where all the electrical signals originate from the heart if you are in a normal, regular rhythm. So what the Aventine does is it slows down the depolarization slope of the action potentials. So if these big spikes represent heartbeats, by decreasing the slope, we increase the time period between the heartbeats and thereby slow the heart rate down. Does that make sense? Yeah. Okay, good. So Aventine was studied in another massive trial called the SHIFT study, in which over 6,500 patients with weak hearts, limited in their activities by breathing, and with heart rates or greater than or equal to 70 beats per minute, but in a regular rhythm, they were put either on automedical therapy. Well, they were all on automedical therapy, but what happened was they either added a sugar pill or the Aventine to this automedical therapy. And they followed these patients out for about 2 years, and they looked to see what would happen to their cardiovascular mortality and their heart failure hospitalizations. Lo and behold, the people on the Aventine, represented by the red line, had much less cardiovascular mortality and heart failure hospitalizations. As a matter of fact, they had an 18% reduction, which is huge in our world. So you see that these two curves separate at 3 months, and by 6 months, it becomes statistically significant. Okay. So these are some of our newer therapies that we have available, but sometimes, despite even the best medical treatment, eventually heart failure may progress. And by the time that you reach stage D heart failure, you may have medical symptoms that are refractory to medical management. And in stage D heart failure, the rate of mortality is quite high, ranging somewhere between 30 to 80%. About 40% of these people will die suddenly and unexpectedly, and another 40% will succumb to progression of their disease. So stage D heart failure is what we would define as advanced heart failure. And out of all the patients with heart failure, about 10% of them will have advanced heart failure. So these, as I alluded to, are patients who have very weak hearts. They're very, very symptomatic, even on automedical therapy. And they likely have liver and kidney damage due to inadequate blood flow to their organs. It is at this point that we would think about whether there are some additional interventions that we can use to help manage their symptoms or prolong their life. Enter the machines. So the left ventricular assist device, or LVAD for short, is one of the machines that we can use to help people with advanced heart failure. And I have a little video here to show you how it works.
The hardware ventricular assist system is an investigational device.
It's actually not investigational
by the United
anymore.
States law to investigational use. The hardware ventricular assist system is a miniaturized implantable circulatory support system for the treatment of advanced heart failure. At the core of the hardware platform is a proprietary suspension system for the wide-bladed impeller. Using a combination of both hydrodynamic and passive magnetic forces, a thin layer of blood is established between the impeller and the pump housing. During operation, there are no points of mechanical contact within the pump, effectively creating a wireless system. The HVAC pump, roughly the size of a golf ball, is capable of providing up to 10 liters per minute of blood flow. Its small size and integrated inflow cannula allow the device to be implanted completely in the pericardial space, directly adjacent to the heart, thereby avoiding abdominal surgery. The implant procedure makes use of a proprietary sewing ring and custom apical coring tool, which allow the pump to be attached to the apex of the left ventricle. The outflow graft is then attached to the ascending aorta. Once in place, blood flows from the left ventricle through the inflow cannula into the impeller. It then exits through the outflow graft to circulate throughout the body. The driveline cable, constructed with fatigue-resistant conductor wires similar to those used in pacemakers, exits the patient's skin and connects the implanted pump to an externally worn controller. The controller is powered by 2 lithium-ion batteries, or 1 battery plus an adapter connecting to a wall or vehicle electricity outlet. The controller operates the pump and features a 2-line LCD screen to display parameters, alarms, and recommended troubleshooting concerning the operation of the system. The controller and batteries are carried in a case, designed to be worn either around the waist or over the shoulder.
Okay. So these are US statistics, and they basically show that the number of LVAD implants has risen exponentially over the past few years, whereas the number of heart transplants has remained largely stagnant. And that is because there has always been, and always will be, a shortage of organ donors. So there are three ways in which we would use an LVAD. So the first way is to actually bridge patients to transplant. Now, these are patients that have actually been accepted already for transplant and are on the transplant list waiting for a heart. However, because of various issues, so for example, maybe they're too tall, 7 feet tall, or maybe they're short like me. It's going to be hard to find a heart that matches their size. Or perhaps they have blood type O, which is, the most rare blood type, and it's going to take about 1 to 2 years for any blood type O patient to find a heart. It is quite possible that they will not survive for that time period, and hence the LVADs can be used as a bridge to their transplant. Also, we can sometimes use LVADs to bridge someone to candidacy. Now, what this means is that the patients are not exactly suitable candidates for transplant in that they have some comorbidities that don't make them quite perfect. So for example, maybe they were recently diagnosed with cancer, but their cancer doctors are fairly confident that, within the next 2 years, they're going to be cured of their disease. Or perhaps their pressures in the lungs are too high, or the kidneys aren't working well because of inadequate blood flow to their organs. So by giving them an LVAD, it buys them some more time so that they can reverse these conditions and eventually become a candidate for transplant. And then finally, we can use these machines as what we would call destination therapy. And these are for patients that are very unwell. They have very weak hearts, very, very symptomatic, very short of breath with minimal exertion, but they are not transplant candidates and will never be. So we can use the LVADs to help them, give them a better quality of life and to prolong their survival for a little bit. Okay, so why would we go through all the trouble of that? Because obviously it's a huge surgery. Well, this figure tells you why. So it's from the REMATCH trial, and it shows you the survival of patients with advanced heart failure. So I want you to take a look at the 1-year mark. People who are just on medical therapy with advanced heart failure live only about 25%. So that's their survival, about 25%. If they are given an LVAD, that increases to 60%. Now, this was with the first generation of LVADs, and this trial was from 2001. Since then, our machines have gotten a lot slicker, and we have gotten a lot better at managing them. So this figure here is taken from the 27 Intermax report, which is a huge registry compiling over 20,000 patients with LVADs across 180 hospitals in North America. And as you can see, the 1-year survival now for patients with an LVAD is over 80%. So we have come a very long way in a short period of time. So really, what I want to leave you with is a message of hope. So yes, heart failure is a growing epidemic. Yes, heart failure does carry a heavy cost to patients, their families, and the healthcare system. But we have medications that will help make you live longer, keep you at a hospital, and help your heart to get stronger. Medical therapy works. I see evidence of this every single day when I'm in the heart function clinic, and that is part of what makes my job so worthwhile. If the medications aren't enough, we do have the machines like the LVADs that are getting smaller with every generation, and we are also getting better at managing them. So it is truly exciting to be part of an evolving field that is changing constantly, and eventually I am quite confident that we will see the day when the machines will become just as good as a real thing. Thank you very much.
Thanks very much, Dr. Poon. So if you have some questions, if you can write them down on the cards, we have some people circulating to provide you with those cards. And so if you take one lesson away, we're not calling it the heart failure clinic anymore. It's the heart function clinic, okay? So just remember that, heart function. Our second speaker this evening is Dr. Ahmed Kayssi. And Dr. Ahmed Kayssi is the most recent addition to the Schulich team. He joined us last July. He is a vascular surgeon who is very well trained, superb surgean, and endovascular operator as well. And he really brings so much experience to our team, and we're really excited that he's joined us. And you will see that he'll talk to you about, I think a fascinating topic is what to do if you have vascular disease in your legs, and what sort of new types of therapies can you be offered in order to improve your quality of life and keep the legs and circulation intact. So a great pleasure to welcome Dr. Ahmed Kayssi, who's speaking for the first time in this forum. So thank you very much for being here.
Okay, thank you very much, Dr. Strauss, for the kind introduction, and thank you, Dr. Poon, for setting an impossibly high standard to our act to follow. I'm very privileged to be here today. I'm a vascular surgeon and a wound care physician. I work at Women's College as well once a week. So I'm going to take a page out of Dr. Poon's book and start off with a small questionnaire, or a single question actually. If you would kindly put up your hand if you have ever met anyone who's got diabetes. Okay. Has anyone here never met anyone who has got diabetes or isn't aware of people with diabetes? Yeah, it's a very prevalent condition. I'll actually give you some sobering statistics. So diabetes affects over 415 million people worldwide. That figure today is actually closer to 500 million people. If it were a country, it would be the 4th largest country in the world. So just to, wrap your head around that figure for a moment. By 2030, at least 550 million people are going to be diabetics, and that's approximately 1 in 10 in every adult in the world. 50% of diabetics don't even know they're diabetics. That's another thing that I deal with in my clinic when people come in with wounds and we're not aware that they were diabetics in the past. And every 7 seconds, someone dies from a complication related to diabetes. Every 20 seconds, someone is amputated. So where do I come in as a vascular surgeon or wound care physician? I meet people with diabetic foot complications. Those are very serious and life-altering conditions. Diabetic foot ulcers affect up to 30% or 34% of people with diabetes. And the risk of death when you have a diabetic foot ulcer is 2.5 times that of other diabetics without a foot ulceration. So once you have that, once you develop that condition, you're automatically placed in a higher risk category. So it's something that we take very, very seriously. We spend about the Americans spend approximately $58 billion a year on lower extremity diabetic care. So we don't have Canadian figures right now, but as you can imagine, it's a fairly substantial amount. And the cost of diabetic foot ulcers is greater than the 5 most costly forms of cancer put together. So this is a major, major issue. This is something that every one of us is going to have to deal with in one way or another, either with ourselves or with our loved ones. This is something that we're struggling to tackle. So in order to understand why it's so difficult to manage diabetic foot ulcers and why so much effort is put into trying to figure out what causes these diseases and how to stop them, you really have to go down to or dig down to what results in the ulcer forming. And I'm not sure how well this projects, but this is a recent article that was published in the New England Journal of Medicine, and it goes through the pathophysiology of diabetic foot ulcers. And really, there are 3 main things that happen to diabetic patients. One is what's called motor neuropathy, where the foot becomes deformed because of the effect of the increased blood sugar on the muscles and the nerves. Sensory neuropathy, where you stop having that protective neurosensation. So think about the last time you were walking on a hot beach or stepped onto something very cold and you sort of recoil. That protective foot sensation has an evolutionary role. It protects you. Well, diabetics lose that, and that's why they're at a higher risk of developing ulcers. And then they lose something called an autonomic neuropathy, where they develop something called an autonomic neuropathy, where they have decreased sweating and they develop very dry skin. So one of the biggest things I talk to my diabetic foot patients in the wound center is about the importance of moisturizing, and especially our male patients. This is not something that people think about very often. So all of those things put together result in something called callus formation. And once a callus forms, with the repetitive minor and major trauma, you develop subcutaneous hemorrhages, which are small bleeds under the skin, and those eventually evolve into an ulcer. So to really appreciate what we're struggling with, let's talk about who's involved in caring for every one of those stages. So when you develop diabetes, you've got family physicians, pharmacists, endocrinologists, internists. When you develop the neuropathies, you've got foot and ankle surgeons, physiatrists, chiropodists. When you develop trauma, you're seen by chiropodists, pedorthists, and offloading specialists. When you have peripheral arterial disease, you're cared for by vascular specialists such as myself and interventional radiologists. And then once you develop a foot ulcer, you're cared for by wound care providers, infectious diseases specialists, plastic surgeons, and social workers. So one of our challenges in limb preservation is that we don't have passionate and eloquent leaders like Dr. Poon in her area of heart disease management. Diabetic foot ulcer management's all over the map. Who's going to take ownership of this disease and really show leadership? So here at Sunnybrook, we're thriving, we're endeavoring to create a team where we can have a one-stop shop for all of those conditions to be dealt with under one roof. And there's no such thing in Canada right now, believe it or not. There are numerous examples in the United States, in Europe, but in Canada, we're really, really struggling to create something like that. So that's our vision here. Part of the challenge is also in changing patient habits. So taking better control of your blood sugars, taking your medications, changing lifelong habits, improving provider collaboration is something that I mentioned, early identification of patients who need surgery or need interventions, and that's what's going to be the bulk of the remaining few minutes I've got with you. Also gathering data to better understand what causes this disease. A lot of times we see people who are referred to us with diabetic foot ulcers with a concern that there isn't enough blood supply, and we do our standard tests and we find that there's nothing that we can change given our current limitations. So how do you gather enough data to better understand and categorize the nature of this disease? These are the challenges that we struggle with as clinicians and researchers in this field. So I'm going to talk to you about some of the latest innovations in managing diabetic foot disease. And as a vascular surgeon, I'm very heavily involved in this because ultimately if they require an intervention or they require wound care or they require down the road, if everything else fails, an amputation, then they end up with our team. So one of the things that we know about diabetic foot ulcers is that the foot becomes warmer than usual, becomes hot. And it's not hot in the sense of a fever where you can actually just put a hand on it. It's a very subtle change in temperature. So a lot of the new technologies have been focused on measuring the temperature of the skin before the ulcer becomes a problem or before the ulcer develops. And so there's a startup in the US called Hoody Metrics that developed this smart mat technology. I'm going to be listing a whole bunch of examples of things that are up and coming. The smart mat, the idea is very simple. You stand on this mat that's Bluetooth enabled, that's wireless, that communicates with a cloud, and that measures the temperature on the soles of your feet. It works by comparing the temperature of one foot with the other, and then developing what's called an asymmetry measure. So it compares the temperature on the left foot, on the right foot, it subtracts the two numbers, and if that number is more than a threshold of 2 degrees, then maybe there's a problem. Maybe you're starting to develop a wound. And it's been validated, it's coming to market, and the idea is that you as a diabetic or your loved one steps on this thing, and then if there's a problem, it starts to beep and it tells you maybe it's time you gave your physician a call. So this has been validated, this has been published, and it's coming to market hopefully very soon. Another company called Siren came along and said, no, that's not good enough. We don't want you to be stepping on a mat. We want you to be wearing socks. And those socks are going to be measuring your temperature and basically collecting data continuously. So this is out of California, and they came up with this smart socks that's going to be ready to ship next summer, I believe. They're already sort of taking pre-orders. And really, you pay $260 US to get this box of 7 pairs of Siren Socks. And you download their app, and then the app communicates with these washable, apparently very comfortable socks, and that collects data on the temperature in your feet, and it sends that data to the app, and then it tells you again when you need to go and see your provider. So that's also been published, and they're coming to market soon very well. How well that's going to work in preventing amputations or preventing problems down the road, who knows? But that's something that you might be hearing about. The third example is a Swiss company that said, well, why don't we see how well the biomechanics of the feet are working? And they developed these things called smart shoes that have a sole that detects various pressures and can be programmed to take the pressure off the area of your foot that is currently infected or ulcerated. The idea is you, quote unquote, offload the pressure from the ulcer so that you're not stepping on it. And it's basically, you've got these mini shock absorbers that can levitate either up or down to reconfigure the pressure distribution on the soles of your feet. This has not come to market yet. I think they're still looking for investors. So who knows if it will come forward or not. But just to sort of get you thinking about some of the things that people are doing. We can't cure it yet, but how can we prevent diabetic foot ulcers from becoming a problem? One is to look for temperature changes or to offload the pressure on the feet. One company called Graftworks, which is in Northern California, came up with a device called the Smart Graft. So the idea is we don't want to measure temperatures. We don't want to ask diabetics to wear things or to put shoes on. We want to implant the device inside of their bodies to continuously send signals to an app or to a cloud or to the provider. And this is really more in the field of vascular surgery. So the idea is that you actually, if you have a bypass graft or if you've got any vessels that are threatened, that you would have this thing implanted inside of you that continuously sends signals and lets you know if there's a problem. So now you don't even have to worry about compliance. It's inside of you all the time. So what you're looking at here is something called an angiogram, which is an injection of dye inside a blood vessel, then you take an x-ray of it. And this is actually a bypass graft that was inserted in the neck of a sheep. It's right in the neck, and you can see the vertebrae there. And the arrow is pointing at that sensor. So the sensor is right on top of the graft. This graft was actually implanted by one of my teachers, Dr. Neville, who's involved with this technology. And what you're seeing here after the graft was explanted, you see the graft and the sensor wraps right around it. And it's constantly sending signals to a cloud-based app that is collecting all this data. So we have thousands and thousands of data points that help us anticipate if you're having a problem with your graft and whether we need to intervene early or not. So this is all very exciting, and you can see where all of this is going in terms of personalized medicine and where the future is heading. Now, one of the other challenges is how do we collect data on people with active wounds? It's very nice to talk about preventing wounds, but how do we actually quantify wound care? How do we quantify what's, what we can intervene on? This is a company called Tissue Analytics that was started by 2 PhD students at Johns Hopkins. They're engineers, and it's based in Baltimore. And the idea is that as a provider, I'm able to take a picture of your foot and get 3D analytic information about what the wound is looking like, how hot is the wound, and what the various elements within the wound look like that'll help me to both triage you from an acuity perspective, but also to measure how well you're progressing. So this is very, this is a very exciting technology, and it's coming to market as well. The other challenge that we have is, well, I get emails from my patients all the time, and I get a lot of pictures, some of which are very gruesome. I can't open them at home. But is there a way to better organize communication with your provider so that you're able to not just have to describe things to them or email them pictures? This is another app that's come to market, started by actually a cardiologist in Ohio called My Wound Watch. And the idea is that instead of emailing people or worrying about calling the office, you simply take a picture and it uploads onto your file, and it notifies your provider, your caregiver, that there's a problem and you'd like the attention that, that someone to help you out. So this is another thing that I'm very interested in, to try and organize how we gather data and how we communicate with our patients. So really, where is this all going? Diabetes and diabetic foot ulcer management is a very daunting field. It's in terms of where we're at, on the one hand, we've got very advanced cardiology interventions and technologies that are really the fruit of decades of collaboration and a focused effort. We lag behind in the world of diabetic foot amputation prevention. So it's daunting, and there's a lot of challenges, but there's also a lot of opportunities. So we're trying to build something here at Sunnybrook to help patients, and also to provide a forum, not just for innovation, but also for clinical excellence, so that you can come and have all your treatments done in a single spot. So yeah, take-home messages are, I hope you have a new sort of appreciation for the scale of the challenge, and also maybe be a bit excited about some of the things that are coming to market. And yeah, the future is bright for diabetics as well. Thank you very much for your
So if you have some questions for Dr. Kayssi, please put up your hand and write it on a piece of paper, and we'll be able to address it later. So the final speaker of the evening is Dr. Eric Cohen, who's the Deputy Chief of the Schulich Heart Program, Deputy Head of Cardiology, and a friend of mine for many, many years. And he's going to speak on a very meaningful topic, which is the 40th anniversary of coronary angioplasty. I started medical school in 1978. As Eric will undoubtedly tell you, the first angioplasty was in 1977. So therefore, my entire professional life, and pretty much Eric's, because he's pretty close to my age, although a little bit younger, has occurred during the time of this amazing innovation that really has revolutionized the way we practice cardiology. So given the importance of really the 40th anniversary of this procedure, Eric will give us some insights and really talk about all the pitfalls and the changes and innovations that came along the way, and we're still doing it today. So it's been an amazing run. So Dr. Eric Cohen.
Well, thanks very much, Brad. I've learned to always be a little concerned when they start asking you to give these sort of retrospective kind of talks about what went on over the last few decades. They're next going to ask you when you're retiring. And, this is sort of the kind of talk that people are looking back. But so, sorry, Brad, but I'm not retiring yet. I'm not looking back. I'm looking forward as well. But it has been a fantastic time to be involved in this field. Brad said his professional career coincides with this. My career in cardiology, I started training in this area about angioplasty in 1988. So I've been around for 30 out of the 40 years of coronary angioplasty, and it really has been a fascinating time. The distance we've covered, the things we've learned, the setbacks we've had. and we move forward strong. So the hardest part about a talk like this is limiting it to 15 or 20 minutes, because I could talk all day on this stuff. It's what, it's what we live and breathe our whole professional lives. So if you want to come back for an all-day session, Brad and I would be happy to chat with you about it. Here's some of it. I'm going to try and cover just a few things. I've really had to trim this to keep to the time. I'll tell you what some of the words and abbreviations actually mean, so it's clear what we're talking about. I'm going to tell you a little bit about the world of coronary artery disease before angioplasty, and talk to you about why the motivation and who invented the practice of angioplasty, some of the successes and challenges. What about the true role? The true role is very inspiring, but it's also humbling, and I'll shed light on that, what I mean by being humbling here, and what the future may hold, of course. So, some words, names, and abbreviations. Angioplasty, all these medical terms come from Greek or Latin, and angio, the blood vessel, and plasty just means modifying or shaping or something. So angioplasty just means modifying a blood vessel. We usually mean enlarging or fixing it in some way. PTCA was the original term applied to this practice of angioplasty. It's a complicated term. The P was percutaneous, which just meant through the skin, without surgery. Transluminal means from inside the artery. You don't have to cut open the artery and work on it from the outside. You do the work from inside. The C was coronary. That's arteries of the heart. And the A is angioplasty, like I explained to you. So widening a heart artery from the inside without surgery seems, completely commonplace and accepted these days, but 40 years ago it was unheard of, and it was a shocking innovation. Balloon angioplasty was doing the angioplasty with a balloon, and that's the original way it was done. I'll show you a bit more about that. We have a different term that we describe what we do now. I don't think it's as good. It's not as descriptive, but PCI, P for that percutaneous, without surgery, through the skin. Coronary, meaning involving the heart, and intervention. Just anything is an intervention. We came up with this term because we started doing things other than just balloons. We widened heart arteries with stents, and things called atherectomy catheters, which are like dentist drills, and a variety of things. And so balloon angioplasty didn't apply anymore, so we came up with this more generic term, PCI, percutaneous coronary intervention. So that's where we are with the terminology. Now, it's all about plumbing. And I have to fix a lot of things around the house, and a clogged pipe, a clogged vessel, that they fill up with lime and calcium deposits and rust, and you put CLR down them and clean them out a bit. But we can't put CLR down our coronary arteries because we don't quite have something that will dissolve the built-up plaque without dissolving the artery itself. Okay, but it's not that different from what you're dealing with at home. At home, sometimes you have to replace your pipes. It's a big job because you have to get behind the walls to replace the pipes. So that's the analogy to doing surgery. If you can roto-root the pipes from inside, then it saves a lot of disruption around your house. And the analogies, I could keep going with these analogies. I don't want to make it seem too contrived, but it is about plumbing. So we move on to the analogy of a clogged artery. And that artery, we're going to talk about the heart, but it can be a clogged artery in the brain. And as you know, that can cause strokes. That can be a cause of dementia. It can be a cause of a variety of things in the brain. It can be clogged arteries in the legs, and that's what Dr. Kayssi was just talking about. Blocked arteries, poor blood flow to the feet is one of the factors that contributes to foot ulcers. And then, of course, it can be clogged arteries in the heart. Now, just enlarge this one for you. So a normal artery is a pipe with an artery wall. It actually has 3 layers, but they're kind of microscopic, so we have to look very closely to see the 3 layers. But the inside should be smooth and clean in an ideal situation. But it's very, very common to develop some buildup of plaque inside those arteries. What's this plaque made of? A whole bunch of things. It starts as some irritation or inflammation inside the artery, possibly because of genetics, what we eat, what we smoke, our blood sugar being too high, blood pressure being too high, and putting stress on the arteries, cholesterol being high and getting deposited underneath the artery wall. Multifactorial, lots of causes, no single one cause. Genetic factors can make you more susceptible or less. Usually genetic factors all by itself isn't the entire cause, but you can't ignore the genetic factors. So on the other side, you see an atherosclerotic artery. Athero just means fatty deposits. Sclerotic means hard, hardening. So that's hardening of the arteries. We used to describe it that way. Your arteries get this buildup of plaque and calcium, which makes them rigid, and it narrows the opening. What we call the lumen is the pipe, the inside of the pipe. It narrows the inside of the pipe. Now, some important distinctions here that I'll come back to in a bit. Narrowing of the pipe versus completely and suddenly blocking the pipe are two very different things with very different consequences. You may not understand that, but I'm sometimes disheartened to know that there's a lot of doctors, including cardiologists, who don't always fully appreciate the distinction between those two things. Because a sudden blockage of the artery cuts off the blood flow to the muscle. That causes a heart attack. You do that in the brain, it causes a stroke. A gradual partial narrowing of the artery may gradually cause chest discomfort because the heart can't get enough blood, enough oxygen to the muscle when it demands more. Or the heart may adapt to it if it develops very slowly. It may cause no symptoms at all. And I'm giving a little sort of foreshadowing here of the humble part of what we do. Because you can develop a lot of narrowings and blockages of the arteries and sometimes no symptoms. And sometimes our attempts to fix it don't really change things for the patients. I'll come back to that a little, but keep that in mind. So consequences, I've just talked a little bit about consequences of clogged arteries. In the brain, it can be a stroke. In the heart, it can be a heart attack, which we call a myocardial infarction technically, but it can also be chest pains, chest tightness, shortness of breath, what we call angina. Okay. It can be narrowing of the arteries to the kidneys, which can contribute to kidney failure. And it can be narrowing of the arteries to the legs, which can cause pain when you walk, or it can cause poor circulation and foot ulcers, which can lead to serious consequences that you just heard about. So one of the solutions to narrowed and blocked heart arteries was coronary bypass surgery. And this was on the scene before we were with coronary angioplasty. The basic idea of bypass surgery is if you've got a blockage in your own artery here, you don't treat the blockage with bypass surgery. You construct a new artery or a new blood vessel that goes around the blockage. So if you've got too much traffic on the 401, you don't deal with the traffic, you build the 407 around it. Okay, that's the analogy. Of course, building a new highway is expensive and you take a longer route. It's got its own issues, right? It can develop traffic jams too. So the bypass grafts can develop problems of their own over time, but at least initially, they tend to be very effective. Bypass grafts can be taken from veins from your leg, and that was the earliest way of doing it. Take the vein and substitute it, basically as an artery, and connect one end to the aorta, the main blood vessel, and the other end to the patient's heart artery beyond the blockage. And you don't have to worry about the blockage. You never go in and try and fix that. Or you use an artery for a bypass. There's an artery that runs down the inside of your chest here, and it turns out that the inside of your chest is just fine without that artery. So you just disconnect one end of it at the bottom and hook it up to the heart. And that's called the lima or lita, left internal mammary or left internal thoracic artery. And it's a true lifesaver. You just notice as an aside, I'm not that good with the mouse with my left hand here. I do angioplasty with my right hand. So bypass surgery goes back a long time, and the word, this slide is from a series of slides about Argentine inventions. Because this surgeon, Dr. René Favellaro, was Argentinian, and he is in many circles credited with really bringing bypass surgery to the point where it could be developed into what it is today. Others will dispute whether he really did the first bypass, because there was different forms in which this operation was done in the early 1960s. Some claim the Russians did it first, but he was working in the US at the Mayo Clinic, and he certainly brought it to a stage where it became widespread. And it was really around 1964 that he started doing that. So thanks to Dr. Favellaro, bypass surgeries come a long, long way. So a couple of years ago, our colleague, Gideon Cohen, no relation of mine, but a good friend and colleague, did a bypass operation where they carried it on Twitter. The hospital tweeted out progress reports every few minutes, and the whole community on social media could follow the progress of the bypass operation, showing that it's come a very, very long way in 50 years rather than 40 years. Well, bypass surgery relied, just as angioplasty relies, on a previous invention before that, which was, how do we know what's going on inside the coronary arteries? How do we know an artery is narrowed or blocked in a living patient? You know, you can do autopsies after life has ended and figure out what's going on. But to figure out what's going on during life, there was other developments about 10 or 15 years before that, in the mid and late 50s, where they figured out you could put a long, thin tube called a catheter in from the leg or from the arm and engage it into the opening of the coronary artery, just outside the heart, and inject X-ray dye, and take basically a series of X-rays like a movie, and it would outline where the artery is
Your
narrowed.
attention, please. Your attention, please. Code white. A alpha wing, ground floor, green zone, room 27. Your attention, please. Your attention, please. Code white. A alpha wing, ground floor, room 27, green zone.
It's a consequence of giving talks in a hospital. The code calls. But anyway, this was the development of coronary angiography. And this is what really opened the door to learning a tremendous amount about what's going on in the arteries of humans during life, and first step to try and deal with those problems, initially with bypass surgery and later with catheter-based techniques like angioplasty. We move forward, and this was the fellow, Dr. Andreas Grunzig, who had the concept of being able to treat the narrowing inside the artery on a beating heart, a living patient, and open or not widen the artery that way without having to do the surgical bypass operation. He had this idea. He was sort of stimulated by a radiologist who had started doing this on leg arteries, but not with a balloon. He had the idea, this Dr. Daughter, about 10 years before, to widen leg arteries by just shoving a tube down there which would push it apart, and then shoving a slightly bigger tube down and a bigger one still, and gradually widen the artery of the leg. That sort of worked to a degree in leg arteries because they're fairly straight and they're not moving. But you couldn't apply this to the heart because you've got to get around all sorts of bends to get to the heart. You've got to work inside the moving heart arteries. So Dr. Grunzig came up with the idea of a little tiny sausage-shaped balloon that you put in its deflated state, and then you crank it up with fluid inside and inflate it like a sausage, and that pushes the narrowing aside. And this is a picture, the very first one he did on September 16th, 1977 in Zurich. That man had a narrowed artery there before, and afterwards it looked like this. It's widened up. And this guy was only 37, the patient, and the doctor, actually. They were the same age at the time. And he faced the possibility of suffering severe chest pains or having bypass surgery. Bypass surgery was not as developed back then, higher risks than he would face today. And, you know, there was a legitimate search for an alternative. And he could have this procedure and go home from the hospital the next day, which was otherwise unheard of. So Grunzig did that on 5 patients initially, and then some more, and reported it slowly to the rest of the world. And it was a huge development. And that's where we really celebrate the 40th anniversary of about a year ago. So this is just schematically or pictorially what he did. A little tiny balloon is inserted into the narrowed artery. And by tiny, we're talking about between 2 and 4 millimeters in diameter when the balloon is inflated. That's the size of coronary arteries. It's even less than that when it's deflated. So you blow up the balloon, and it pushes the plaque aside, and then you deflate the balloon and take it out, and the artery should accommodate better blood flow because it's wider. And so when you think about where we were in terms of improving blood flow to the heart muscle, bypass surgery was a large operation, open chest, heart has to be stopped and put on a heart-lung machine. There's higher risks and slower recovery. I mean, I'm talking about 1977 here. Some of this is still true, although the risks are less than they were then, the recovery is quicker and so on, but some of it is still true. On the other hand, you had some advantages, a very durable result. Once you got those arteries of bypasses connected, it tended to last. And it was well suited for patients who had lots of narrowings, because with 1 bypass, you can deal with all the narrowings in that artery. And with 3 bypasses, you can deal with basically the whole heart. And once you're in there, it's not a big deal to put the 3rd or the 4th bypass. People talk about it as a badge of honor that I had a quintuple, but it's largely the same operation as having a double. You know, it's another 15 or 20 minutes, but it's a clear advantage. When you do an angioplasty, you treat each narrowing separately. So it really is a bigger deal to have 5 narrowings treated than 1 or 2. So angioplasty advantages, it's quick, it's from inside on a beating heart, there are lower initial risks and a rapid recovery, but it's a little less reliable, especially in the days of balloon angioplasty. There was complications. The artery didn't always widen in a nice predictable way. It sometimes tore. Or if you got the artery open, it often came back again. Scar tissue formed, and 3 months later, you had its narrowing just as bad as you had before. And if you had multiple narrowings, of course, the difficulty increases and the risks increase. So it wasn't well suited for multiple narrowings. That prompted the search for better solutions. And one of those better solutions, and in fact what's come to be very much a part of our practice, is the development of stents. Stents are little wire mesh tubes or scaffolds that prop open the artery. And they really had 2 main effects. It made the result more predictable at the time because the artery wouldn't tear or block off of the blood clot so much. And it held the artery open, bigger, so that it was less likely to re-narrow. You could still get some scar tissue inside the stent, but because you start with a bigger opening, it didn't tend to block the artery as much. That was the development of stenting. And the first stents were put in, I believe, but Dr. Strauss can confirm, around 1988. And one of the earliest publications about coronary stents was Dr. Strauss himself when he was in Rotterdam. Thank you. Although, if you know the truth, it almost put an end to the whole technique at that point because they documented some of the major problems with blood clots forming on these metal stents that are stuck inside of our arteries. Our blood doesn't like foreign bodies inside, especially metal, and tended to form clots. We got over that by realizing that you have to give patients blood thinners, different types of blood thinners to avoid the clots, and we sort of got beyond that. One of the points I want to make about angioplasty is it's what I call a highly visual specialty because it's based on looking at those angiograms. The X-ray machine is a camera, so a camera is an inherent part of the procedure. So everything we do is visualized, and everybody can see the record of that forever. Dr. Grunsik believed, he was a great teacher. I never knew him, I never met him, but he was a great teacher who believed that the only way to get other people doing this is to bring them together and watch him do cases. Because it's all based visually on what's going on in the angiogram. That could be broadcast into the conference room and the trainees could watch. And so it became a badge of honor to go to one of Grunsik's live demonstration courses in Zurich. And if you were at the first one or the second one, you wore that like a medal in your angioplasty career. Now tragically, Grunsik died at a young age in 1985. He had moved to the US. He was an energetic and adventurous guy, and he learned to fly. And he progressed quickly into twin-engine planes, perhaps a little too quickly, and unfortunately he and his wife crashed in his private plane when he was, I forget how old, but I think he was only 45 at the time, and so his own personal contribution was lost. But his legacy was well established by that point. So as I said, you don't have to bring a camera in to watch it or film it because it's filmed as part of the procedure. So stents became, I call the good, the bad, the ugly, and the beautiful. They gave us this predictable result, but then we had this problem of so-called stent thrombosis, where the stent clotted. We partly solved that by more blood thinner drugs. The problem of scar tissue forming inside the stent, we thought we had solved by putting drugs on the stent, some of them similar to anti-cancer or anti-rejection drugs, to avoid the scar tissue forming around the stent. Seemed to work, except we then had a bigger problem of clots forming around the stent because the drugs were too good at preventing any scar formation around the stent. So the bare metal stayed exposed to the blood forever instead of being covered by a thin layer of tissue, which was actually protective. We got around that eventually by modifying the drugs we used to thin the blood, keeping people on them longer, and making these drugs on the stent a little more friendly so that they don't completely stop any healing around the stent. And with that, I would say that current stents are close to what we call beautiful. And here's, I'm not going to tell you all the technical details, but the stents are mostly made of metal, various combinations and alloys of metal to get visibility on X-ray, flexibility, strength, and so on. You can see all these little patterns here. The way they're built is lots of variations of how the links come together to give them a combination of flexibility and rotation and strength, a huge amount of engineering into that. They get thinner as we move forward in time, and the drugs coating them get more friendly over time. So we've moved into second and third generation of these stents. And the net result is they're tremendously flexible, they're very small, so they're easy to get into the arteries, and they're strong and they're durable. And all of these problems, they still exist in small numbers, but not nearly the issues we had in the past. So nothing's perfect, but stents, modern stents are fairly close. There's other big movers and shakers that brought us forward. One was the medications, as I mentioned. You may have heard of Plavix and other drugs like it. I'm not selling anything for drug companies here, but it was a game changer for us because it allowed people to get a stent and not need to take really toxic blood thinners, to take a convenient, relatively safe blood thinner and prevent the stent from clotting. And the other huge development is the imaging. It's all an image-based specialty. This was Dr. Grunzig's first immediately post-balloon angioplasty result. You can see the effect there, but it's not a very sharp picture when you start wanting to work on smaller arteries in more details. So a huge amount of progress in the X-ray technology and cutting down on the radiation levels to make it safer for staff and patients and so on. And other things that have happened with imaging. So cardiology is a very image-dependent, taking pictures of the heart, very image-dependent specialty. One of the things we have now are CT scans that can almost duplicate. A CT scan, you don't have to put any tubes inside. You just have to put an intravenous to give some X-ray dye in. And you can, in much of the time, get these beautiful pictures that show you what the arteries look like and some additional information without having to do an invasive angiogram. And you can see, you can recreate these 3D models of the heart and the major blood vessels like the aorta and smaller vessels like the coronary arteries. It's becoming a very useful technique, and we learn a lot from it and benefits patients as well. We've also learned more from developing ultrasound catheters, so the kind of ultrasound that we use in obstetrics or echocardiograms to look at the heart from outside. We can miniaturize the ultrasound to look at the blood vessels from the inside. So you take an angiogram, and the blood vessel looks fairly smooth, and you might think that's normal. But when you put the ultrasound, the sound wave pictures inside the artery, we can see that this is plaque. This is that atherosclerosis building up. The artery should be this outer circle, and all of that crescent-shaped thing is plaque on the inside. So we get a much better view of what's really going on. So again, we learn a lot more about how to control this, when it's an issue, when it's not an issue, how to choose the right size of stent, and things like that. More recently, instead of using sound waves from inside the artery, we use light waves. Because light has a much shorter wavelength, we get much higher resolution pictures. And here we can see another plaque. But now what we're looking at is this very thin layer over the top of it, called the cap, or a thin cap. A thin layer of tissue over a fatty collection of cholesterol and fat stuff is a dangerous situation. Because if that thin cap erodes or cracks, then the blood is exposed to all this fatty material underneath. And that's what causes heart attacks. That's what causes sudden blood clots to form. So this kind of plaque is more dangerous than one that might be very dense, chronic scar tissue. So we're learning to distinguish between not just how much is the artery narrowed, but what's the nature of the plaque that's narrowed. Okay, what the future might hold. Resorbable stents, stents that go away. Holographic imaging. There's already some prototypes of this, where instead of looking on a screen in 2 dimensions, the image of the heart and the artery is projected in front of my face while I'm working in 3 dimensions, and instead of manipulating the table and everything, I reach out and twist the heart in space. There's no real heart there. It's just virtual reality, but it's amazing. And robotics, potentially, for greater precision, to be able to do a procedure from here with a patient in North Bay where they don't have the facilities to do that, and so we can all avoid some of the radiation exposure. I say this is what the future might hold. There's no promises about any of these things. And there's actually a little bit of a lesson here. So, question for the audience, who's that? Yogi Berra, right? It's hard to make predictions, especially about the future. That's one of Yogi Berra's hundreds of amazing quotes. And yes, it is. So I said resorbable or disappearing stents. It sounds like a good idea because if you're young and you need stents in, but you're facing 40 more years, it's probably better to have your artery heal and not have that metal in there all this time. And if someone needs to do bypass surgery and there's a stent where they want to sew in the bypass beyond the original block, you can't do it if there's a stent there. So dissolving stents seem to be a good idea. And there's a lot of evidence in animals and early work in humans that this seemed to be great, and it would be the sort of holy grail. However, as more follow-up came through and the patients had them in longer, we realized that despite the intuitive appeal of that idea, it wasn't working out well. These stents were clotting and causing problems, causing heart attacks and so on. So it's back to the drawing board on these resorbable stents. Maybe they'll come back, maybe we'll fix the problems with them, but it's a humbling lesson that what we think is attractive and is going to work doesn't always pan out that way. Let me tell you one thing that's inspiring though. So remember, back to the arteries, if you have a completely blocked artery, sorry again about my mouse skills, but if it's completely blocked, the area downstream doesn't get blood or oxygen and the muscle can die. And it can die pretty quickly if it doesn't get the blood flow restored. So one of the places we use angioplasty now is to very quickly try and open a blocked artery. Okay? And that's because that's in the context or setting of an acute heart attack. Heart attack happens, so this is the ECG you get when you go to your doctor, and I'll tell you a little secret, most of the time they're not that helpful, these ECGs, but if you're in the midst of severe chest pain, it is very helpful, because it often or sometimes shows that this part of it, which we, for technical reasons, call the ST segment, it's elevated off the baseline. So that's ST elevation myocardial infarction, or STEMI for short. The most common word in an interventional cardiologist vocabulary these days is STEMI. And this is an acute heart attack. So I'll show you just a couple of pictures. This artery completely blocked off, right? It should be going down here. After they've opened it, there's all this artery. So this whole area wasn't getting any blood flow. This artery here, big important one in the front of the heart, completely blocked off. Now it's open. And this one here, the right coronary artery, again, completely blocked. Now it's open. Okay? You didn't see it, now you see it. I always say this is like the Leon's commercial. It's a miracle. It comes back. But to do this promptly is not technically that hard much of the time once the patient's there in the procedure room on the table. The tough part here is getting them to the table quickly. That requires a huge system of care. Educating people to respond promptly to chest pain, having the ambulance services respond promptly. They now do the ECG in the field, at home, at work, wherever you are, to make the diagnosis immediately, or at least make a potential diagnosis. Then instead of taking you to the closest hospital, they may bypass that hospital and take you to the closest hospital that has angioplasty capability. So this is all called the Code STEMI protocol. And it's highly organized in Toronto. The city's divided up into zones. You know, you may not need to know that, but we know that, and the ambulance services know that, and they bring you to the closest hospital. Everybody's notified ahead of time, and so on. A tremendous amount of work. It took, you know, several years to get these systems up and running well. But it does tend to run fairly well, and it's made a big difference to people's lives. There is a problem here when we have a system like this. You can be exhausted because this is middle of the night work. This is after hours work. This is the frustrating thing of someone who comes for a scheduled angiogram and is waiting all morning for it and gets bumped because someone with an acute heart attack came in and has to take precedence there. So the Australians just told their doctors, drink more coffee. I'm not sure that's the real solution. So it has changed the way we work a bit. So what the future might also hold, more precise characterization of risk. Who's really at risk and who's not? That's genomics, gene. More complete and accurate outcome data, the so-called big data that Dr. Kayssi was looking at from some of the foot sensors, for example, which could mean more personalized treatment choices. On the other hand, we should be realistic. There's some other forces at play here. And of course, we're all trying to be more transparent and accountable as providers and payers to the public, to patients, about what we're doing and how well we're doing it. And there's ongoing, always, cost reduction pressures. And those things can sometimes mean a push towards more standardized treatments, which in some ways is the opposite of more personalized treatments. So when you hear about personalized medicine, yes, it's coming, but it's being counterbalanced by other forces as well. So it's a complicated scenario that's going to play out. One last thing, I'm going to answer it. Does stenting, do stents accomplish anything? So if you watch the New York Times headlines or this article from the Atlantic Monthly about 2 or 3 months ago, they were reporting on a small research trial from the UK that gave half the patients a stent for their chest pain syndrome. This was not emergency, this was planned, elective. And the other half of the patients, instead of getting a pure so-called placebo, they got what's called a sham procedure. They got most of the procedure, they just didn't get the stent put in, because there's come to be a bit of a realization, and it's not a trivial fact, that undergoing some sort of procedure changes the way you perceive your symptoms, even though it may not be widening the artery. So on one hand, that's a bit humbling, because it did question whether, at least in some patients, our stents are doing anything. Just thinking you got a stent seemed to do as much. Okay. Now, we had some criticisms about the way the study was done and so on, and it could be done better, and it'll be replicated perhaps. On the other hand, it's a little inspiring, because it does point to the fact that human hearts and other parts of humans have the ability to adapt. So when one artery narrows, in many cases, the other arteries will take over to a degree. And, you know, we are more adaptable than we realize. And I think our job as cardiologists and cardiologists who put in stents should be to be judicious about where and when we put in those stents, recognize the ability of the human to adapt to adversity inside and outside, and be humbled by that. So we keep those two perspectives in mind, I think we achieve the best choices and the best outcomes. So I told you a little bit about the terminology, what was here before angioplasty, Dr. Grunsig and his motivations to invent balloon angioplasty, our true role, inspiring and humbling, and the future may hold really exciting stuff, but we'll have to wait and see. Thanks very much.
Thanks, Eric, as always, fantastic presentation. Maybe I can ask Ahmed and Stephanie to come up to the podium here. You know, it's interesting that interventional cardiology in particular, which both Dr. Eric Cohen and I myself do, is really a combination of innovation and engineering along with imaging. And it's, you know, we're talking about 40 years of coronary angioplasty. But if you actually go back to the 1920s, there was a German doctor there named Werner Forssmann who actually started this whole thing. And Dr. Forssmann, at the age of 25, decided that there may be something very interesting in trying to get a catheter into the heart. And no one had ever done it before. So he decided to do it on himself. And he actually took a ureter, a small catheter that the urologist used, put it into his own vein in his arm, and then he walked over to the X-ray machine, and under the X-ray, he actually threaded this catheter up into his heart and took a picture of it to prove that he had actually got all the way into his heart with the catheter. When his boss found out, he was actually fired, and subsequently, he went in and he became a urologist. But the amazing thing is, for doing that very brave and somewhat questionable act of innovation, he did receive the Nobel Prize in 1950. So you never know what kind of crazy stuff you can do. And interventional cardiology, to be honest with you, is full of people who've done a lot of crazy things. So you never know where you end up with it. So we've got a bunch of questions here. Great. So, by the way, thanks everyone. This is often really a lot of fun to ask these questions because they're often very tricky and controversial and put people on the spot, and that's what's fun. So, let's start off with Dr. Kayssi. I'm a type 2 diabetic on insulin and medications. I recently had a bypass surgery. My legs at night jump in bed. Should I be concerned? So.
Can you hear me?
I think you have to press down on it.
Okay. Does this work? Yeah. So I don't know if I turned the light on. It's difficult to answer this question without obviously meeting you and examining you. There are multiple reasons why you might have discomfort and jumping legs at night. I would recommend that we either chat afterwards or you can follow up with your primary care physician. There are medications that can be given for that. Sometimes those are, this condition is a consequence of the peripheral neuropathy that I mentioned earlier. So there are medications for that. And regardless, if you're a type 2 diabetic with or without a bypass, you should have what's called a wellness foot exam. So someone should be looking at your feet to make sure that they're well moisturized, that there are no cracks, that there are no ulcers or any conditions that would require further attention.
Okay, thanks. Here's a question for Dr. Poon. Can these two new heart medications be administered to people in their 90s with congestive heart failure and kidney disease? So how do you decide of all the patients out there, which patients can have it and which patients cannot?
Hello? Oh, great, that worked. So yeah, that's actually a very good question. So essentially, it doesn't matter how old you are, as long as you have a weak heart, you're limited in your activities by breathing, but some of the other criteria that we look at is, for example, is your blood pressure high enough? So one of the side effects of the Entresto is it lowers your blood pressure, right? So in order for you to be a candidate for this new medication, the Entresto at the very least, you need your top number to be at least 100. So if your blood pressure is too low, then we cannot safely start you on this medication. Also, your kidneys can be a little bit impaired, but if you have significant kidney dysfunction, then again, we cannot start you on this medication, because one of the side effects, if your kidneys are very bad, being on this drug can injure your kidneys a little further. And if your potassium levels are high, again, we cannot start this medication, because one of the side effects is it does raise potassium levels. So those are really the contraindications that we look at. It doesn't matter how old you are. If you have great blood pressure, your kidneys are okay, and your potassium levels are fine, then, and you have a weak heart, obviously, with symptoms that limit your activities, then you would be a candidate for this medication. Now, was the question related just to Entresto, or did you want me to talk about
It's about age and kidney dysfunction. Like if you're over 90, can you get one of these? Like, do we get restricted by age of someone?
Definitely not. And actually, the Aventine, it's even more broadly used. So if you have kidney dysfunction, it doesn't matter. If your blood pressure is low, it doesn't matter. You can use Aventine too. But really, Aventine only has the best benefit for people whose heart rates are over 70 beats per minute to start.
Okay, and atrial fibrillation? And
no, you can't be in atrial fibrillation. So for Aventine, you have to be in a nice, normal, regular rhythm for it to be effective. Because remember, it targets the sinus node, and that's where the electrical signals come from, only if you're in a nice, regular rhythm. In atrial fibrillation, the electrical signals come from everywhere within the atria, so the Aventine would not be effective in those patients.
Okay. Thanks very much. So for Dr. Cohen, 45-year-old man, I don't think the age actually really matters in this particular question, who had a stent placed for a STEMI last year. He was told he had a 55% blockage in another coronary artery. Why would this not be treated also?
Good question. It's an active research in cardiology. First of all, 55% narrowing is fairly borderline. You know, if a narrowing doesn't actually interfere with blood flow, even with, you know, when you exert yourself and need more blood flow for the heart muscle, 50% narrowing in that ballpark usually doesn't actually interfere with blood flow. There's enough reserve in these arteries. In a sense, they're bigger than they need to be, or they can dilate a bit under demand. So, you know, 50–55%, we most of the time would leave that alone, okay? If it was more severe, then it's still a question. What if it's 80%, but the person feels fine after they got the first stent put in? What are we treating? Do they feel fine already? We're not going to make them feel any better. If we knew for sure we're making them live longer, then it's worth doing it. But we definitely aren't sure about that, especially when that second narrowing is in a smaller blood vessel that doesn't serve a huge part of the heart, or when we haven't got evidence that it's actually restricting oxygen delivery to the heart. So there is this concept, what we call complete revascularization. You go and you stent or you bypass with surgery every narrowing that's there. You know, you try and get blood flow back to what it was in the sort of when you came out of the box, right? Or there's the other concept, what we call culprit only. We treat the one narrowing that is causing the immediate symptoms or cause the immediate heart attack problem. We leave the other narrowings alone if there's no symptoms. And to be honest with you, we don't know the answer between those two strategies. We've done a lot of research studies and some big ones coming up. So right now, you know, we have to make the best possible decision. And much of the time, we would leave the non-culprit narrowings alone if they're not causing symptoms.
Okay. Here's some more. Okay. It's a question for all of the panel. And the question is, and I'm going to sort of change it a little bit as a prerogative of the one asking the question. Comment on current commercials by one company on carrying 2 81 milligrams aspirin with you. So I want to change a little bit about, first of all, do you yourself take aspirin prophylactically? And secondly, do you think, what do you think of this idea of carrying around aspirin in case you suddenly have a heart attack one day? So first part is, do you or do you not take aspirin yourself? What do you tell patients about taking aspirin, and would you advise anyone to carry it around with them if, God forbid, they had a heart attack? So, yeah, we'll go right across.
I'm going to plead the fifth on the first part of the question by answering it about myself, because I'm strictly evidence-based, and I would never do anything based on emotion. Aspirin's a complicated issue. If you've had a stroke or you've had a heart attack, there's absolutely no doubt you should be on an aspirin. It's almost always a baby aspirin once per day, and there's overwhelming evidence that that reduces risks of second heart attack, second stroke, and so on. Sometimes we use alternative medications like Salvage or other ones that are similar to aspirin, but that concept of mild blood thinner like aspirin is unequivocal if you've had an event already. If you're just taking it to prevent something and you're perfectly well and you don't know if you've got any narrowings or blockages, it's a lot less clear. There's a lot of studies which are not the ideal type of study, what we call observational studies, where they look at, oh, these people took an aspirin a day and they lived longer, they didn't have the heart attacks, and these other people didn't take an aspirin a day. But the people who chose to take the aspirin a day are often healthier, wealthier, and wiser to begin with. And that affects your health, your outcomes. So it's not clear if it was the aspirin changing it or where they started from. So it's really not that clear for so-called primary prevention. And the reason is there's a potential downside. Aspirin has a small but real risk of causing unwanted bleeding, including in very rare cases bleeding in the head, which is devastating. The second question was, should you carry them around with you? And I know a company that advertises that. You should definitely take 2 aspirins quickly if you believe you're having a heart attack. Whether you really need to have it yourself, I think the more important message is call 911. They'll be there within 8 minutes, and they'll give you the 2 aspirin. And I don't think there's any evidence that that 8-minute difference matters. An 8-hour difference will matter. So if you sit at home with chest pain and don't call anyone for 8 hours, that's bad.
Okay. Members of the panel who don't want to give in any personal details like Dr. Cohen refused to, but he had.
So I don't take aspirin currently, but you know, the rate I'm eating the Sunnybrook cafeteria food, I'll probably be starting very soon. So you know, I echo Dr. Cohen's sentiments. I think if you live in the GTA, and clearly the people here tonight are very involved and self-aware, I think we are very privileged to have access to many great systems that were highlighted in the previous talks. I was just in Sioux Lookout last week in Northern Ontario, and some of the Indigenous communities up there have very little access to healthcare. And with an incidence of diabetes of over 50%, making it some of the highest in the world. So, you know, if you live there, clearly I would want everyone to be on aspirin. Whether or not, as Dr. Cohen said, there's evidence that, you know, carrying a couple of pills with you all the time is advantageous. Frankly, I'd be a bit skeptical without seeing more research around that. You know, another question is statins. I'm very passionate about cholesterol lowering, and I know that's a whole other sort of can of worms, but that's another thing that I think needs to be very strongly considered. So, yeah.
Okay, Dr. Poon.
Truthfully, I don't think there's much more I have to add. I think this question, for every individual, there's going to be a different answer, truly. And I think, you know, it doesn't really matter if you know what I do, because the answer for you might be something different, right? It all depends on, A, whether you've had a heart attack before. If you have, you definitely should be on it, like Dr. Cohen said. And B, perhaps if you have, you know, more risk factors, so for example, if it runs in your family, if you smoke, if you have diabetes, if you have those things, maybe it's a good idea to take an aspirin as well. But you know, it all depends on what you're bringing to the table as an individual, what your individual risk is as to whether this is a good strategy for you or not. But certainly, you know, if you think you're having a heart attack, as Dr. Cohen says, you really can't do any harm by popping a couple of aspirin.
They're not really letting me look into their life at all. I'm disappointed, but okay.
Do you take an aspirin?
Yeah, I do actually.
But that's for a headache.
No, I do. Based on the physician studies, which are they're flawed, and for sure it's a huge controversy. Now, I'm not saying to do as I do, because I probably would have stuck the catheter up my arm like that. I'm not sure I would follow any of my advice. Yeah, I think it's an excellent question around panel as well. On average, what lasts longer, a bypass graft or a stent? And I think we could talk about it in the legs, we could talk about it in the heart, and then Dr. Poon can give us an unbiased one as someone who doesn't do either of those two procedures. So let's have a bypass graft versus a stent.
Again, I think it depends. So again, there's no clear black and white answers in medicine, right? It really depends on what the individual looks like. So for example, if you have a lot of blockages in your heart arteries and you have diabetes, and chances are you're going to have better outcomes with bypass grafts, right? But if you're not a diabetic, you don't have a weak heart, and you've got just one little nice discrete blockage that they can just put in a little stent in, then hey, maybe stenting is also a fantastic alternative. And, I think most patients would prefer having angioplasty in those circumstances too. So I think really it depends on whether you have diabetes, a weak heart, multiple lesions. Those patients probably do better with bypass surgery. And I think that's where I'll leave it at, and I'll let Dr. Cohen kind of fill that out.
Well, people are asking great questions because you're touching on all of the major controversies in cardiovascular medicine. These have been controversies for decades, and they haven't settled them. Part of the reason it's hard to answer these questions is because the technology moves forward while you're trying to get an answer. So by the time you get an answer, you say, well, if we did the study again with newer stents or newer bypass surgery techniques, you might get a different answer. And indeed, the answers have differed a bit when we study this over the years. So in general, we think of young people like to get stents, older people get bypass surgery. The reality might be the other way around, because when you're young, your risks from the bypass surgery are lower, your recovery is likely to be quicker, and you do have this interest in a very durable result. And remember, I showed you that left internal mammary artery that connects to the front of the heart. That was the innovation in bypass surgery that really gave it a benefit on survival. If you get that kind of bypass graft, you do tend to live longer than someone who didn't get that kind of bypass graft. And in fairness, every time we've compared surgery to angioplasty doesn't fare quite as well for people who've got narrowings in that front artery of the heart, where they might be able to get that kind of left mammary bypass graft. So it's not so much a question about how long one or the other lasts. What happens is you develop new narrowings over time. It's a chronic disease. We do our best to slow it down, but you do tend to develop some new narrowings over time. And if you've got that bypass in place, it does help with survival. But for many people, either option is quite good, and some of it is personal preference, lifestyle choices, and things like that. When we think that the differences between them are small, then personal preferences and lifestyle choices are very important and legitimate.
Dr. Kayssi, about the leg, where you have also the option of both, right?
Yeah. So, one of the privileges of working at Sunnybrook and being part of the Schulich program is that I'm given the opportunity to do both. So I do both stenting or angioplasty as well as bypass surgery as a vascular surgeon. And this is a very emotional topic in certain jurisdictions, especially south of the border, where there's a particular tribalism in our approach to debating this. So you've got the one community. I'm not talking about the coronary arteries. I'm talking about legs. You've got a group of people, mostly interventional radiologists, who are very gung-ho that you need to have the angioplasty, that the days of doing bypasses are gone and barbaric and too morbid. And on the other hand, you've got a curmudgeonly group of vascular surgeons who are sort of adamant that you need to have a bypass procedure. at all costs. So the answer is that in truth, that nobody knows just yet in 2018 what the gold standard is. Like Dr. Poon said, it depends, which is sort of a very favorite phrase for physicians to utter in clinic. We actually at Sunnybrook got certified just yesterday to join the BEST CLI trial. It is the largest clinical trial in vascular surgery right now, and interventional peripheral arterial surgeries, looking at bypass versus angioplasty for what's called critical limb ischemia. So that's when we have rest pain, we have foot ulcers. We don't know, and there are over 100 other centers recruiting across North America. So we're very excited, and maybe if I'm invited here in a couple of years, I'll have the answer to that question. But right now we're recruiting patients, and we'll keep you posted.
Every Friday morning we meet with cardiac surgeons, the cardiologists, and we have these debates almost every case. There are certain principles I think that we all agree to, but like most things in law, it becomes very case specific as you go through it. So it's a great question, and not one that you can get a straightforward, easy answer to, although the principles I think most of us agree upon. So let me ask that. This is, I think, an interesting question. I'm going to phrase it in a way that I think for our panel. So Eric talking about coronary disease interventions, Dr. Kayssi about peripheral vascular disease, and Dr. Poon about heart failure. Can you talk a little bit about, first of all, whether you think women present differently than men in your specific area of expertise, and are they being treated differently? So both questions there. So wherever you want to start. Eric, go ahead.
So there's been a lot of interest over many years about, do women have different symptoms when they develop narrowings in the coronary arteries? First, the more basic question was, do women get that at all? Because there was some, some doubt about that. This is, a decade, half a century ago. Yes, women get coronary disease, vascular disease, just like men do. It tends to be an onset, in general, on average, a bit later in life. It may be that hormonal patterns protect women up to a certain age relative to their male counterparts, but women get the same kind of disease. So then there's a debate about, are the symptoms different, and are the symptoms going unrecognized and undertreated because they're not the classic textbook symptoms that seem to have come from interviewing male patients, who clutch their chest and complain about elephants sitting on your chest. My feeling about that has always been, yes, women have a lot of different type of symptoms, but when you treat a lot of men too, that classic textbook of an elephant on the chest applies to a minority of either sex. So you have to have an open mind to people's symptoms regardless, men or women. There are some specific nuances and variants of coronary disease that are more common in women and sometimes less recognized. I think we're trying to sort of go through an educational process and understand that a bit better. I didn't talk about it, but women more often get a condition where the artery could be perfectly normal with no buildup of plaque inside, and you get a little tear in that line. I showed you there's 3 layers in the artery wall. The inner layer can tear, and you get the artery loses, it sort of spirals and blocks, and we call that a spontaneous coronary artery dissection. And it presents just like a heart attack, that ST elevation, that chest pain, everything. But the treatment usually is not an immediate angioplasty. Often the treatment is to leave it alone because it will heal on its own. And so that's one of the unique variations. And now that we tend to do immediate angiograms in so many people with presumed heart attacks, we've only just learned this in the last decade or so. So it's part of where changes in treatment and technology actually teach you more about the disease you're dealing with.
I want to comment though on the ratio of male to females in most angioplasty studies, which are typically 75% male, 25% female. Why is there such a discrepancy?
Well, so you got to distinguish between the ratio in studies versus the ratio in day-to-day practice. It's quite different, and we've been criticized, I think rightly so, for that we do not enroll women in research trials in the same proportion that women are, make up a proportion of our patients. And so the proportion of women in a patient population is often related to the average age of that population. If you look at people undergoing aortic valve replacement for stenosis, that tends to be quite an elderly population, much higher proportion of women. If you look at people undergoing acute MI treatment for heart attack, younger population on average, slightly higher proportion of men. But in the research studies, women are underrepresented for a variety of reasons. They may not be approached, asked to be part of the study. They may have concerns or question marks about it. There's exclusions we build into the study that tend to apply often more to women. So we sometimes find that we're lacking data and evidence on how to treat women properly. So it's become an issue we're aware of, but I don't think we've totally addressed it and solved it.
Kayssi?
Sure. So this is an area that's very near to my heart. I spent the summer actually looking at the representation of women and ethnic minorities in vascular surgery clinical trials, and then we got published. And as you can imagine, they're not very well represented. As far as peripheral arterial disease and vascular disease go, the bulk of our data comes from large studies that were done in the United States in what's called the VA hospitals, Veteran Affairs, which are mostly veterans of the various U.S. wars. So you can imagine there aren't that many females in that cohort. But what we know, at least we do have someone who's very active in this research in Canada, Dr. April Boyd, who's the chief of vascular in Manitoba, Winnipeg, and she's published quite a bit about this. We know in aneurysmal disease that women present very differently. So those are the abdominal aortic aneurysms, thoracic aneurysms. As far as peripheral arterial disease, we know that they present later in life and tend to have slightly higher complications because the vessels are smaller. So the reasons for that and the pathophysiology, if you will, has not been fully understood. But I think at least in NIH in the United States, you now have a requirement to be representative if you want to get government funding for studies. So this is going to be solved in the future, hopefully, as we enroll more representative populations in our studies. But right now, most of our data is based on old studies that were not very representative, so we can't answer these questions very well.
Dr. Poon, heart failure world?
Yeah. So in the heart failure world, I mean, we suffer from the same criticism with respect to our heart failure trials. Again, more men in those trials, less women. However, heart failure as a condition is a great equalizer. So both men and women are treated and suffer the same symptoms in heart failure. They all get short of breath, they get swollen. So regardless of your sex, you're going to feel it the same way, you're going to be treated with the same medications.
Okay. So maybe, Dr. Poon, a question here, and I'll just change a little bit. My systolic blood pressure 150 and over, diastolic pressure is 60 or normal. So I want to ask you, in terms of systolic blood pressure in particular, and maybe Dr. Steve want to discuss it, you want to discuss anything about the SPRINT trial and some of the new, the suggestions about how we should be treating patients that have elevated systolic blood pressure, that we're being much more aggressive in terms of lowering it to lower numbers than in the past, and how does it relate to heart failure management, blood pressure control, which is, I think, a pretty important part of what you're doing.
So recently our high blood pressure guidelines have become a little bit more stringent, such that the target blood pressure for starting medications has become lower. So they've actually lowered the threshold of what is determined to be high blood pressure now. So I think the number they're aiming for currently is about 130/80. And with those numbers, a lot of people will end up having high blood pressure, right? In my world, the treatment of heart failure is more important for people who have heart failure with preserved ejection fraction, namely the people who have strong, stiff hearts, right? So, or diastolic heart failure. People with heart failure, preserved ejection fraction run into trouble if their blood pressure gets too high. So you can imagine your aorta, which is the main blood vessel to which your heart's connected to. If the blood pressure is high in that huge garden hose, and your heart has to work that much harder to get the blood out. So by lowering the blood pressure, that facilitates the work of the heart. For people who have weak hearts or heart failure in the context of reduced ejection fraction, heart blood pressure lowering is not as important per se, but it often is one of the side effects of the medications that we use. So I guess in that context, and also a chronic history of high blood pressure can sometimes cause weak hearts as well. So if you have very long-standing high blood pressure that's unmanaged, by actually controlling it, we can actually reverse the damage done to the heart and make the heart strong again.
Dr. Kayssi, for diabetics, patients who are diabetic, patients in the audience, how should they look at their feet or watch their feet in order to know when to be alarmed by what they're seeing, and when should they have arterial studies done to look what the circulation is like in their leg, so that they preempt the terrible amputation or something along those lines?
Yeah, absolutely. So it's very important to take very good care of your feet. Whenever you go to your primary care physician, your family doctor, you should ask to have your feet inspected. If you don't have a relationship with a chiropodist or a foot care expert, I suggest that you seek one out. It doesn't have to be a regular thing, as in weekly or monthly. Even once a year is fine. But if you are diabetic, you should be very conscientious that the process that is going on in your body will very likely eventually cause you to have diminished sensation in your feet. And it doesn't have to limit your lifestyle. You just have to acknowledge it and plan around it. There are certain types of shoes that you should be considering. You can try and avoid walking barefoot, or during these trips to Florida, try and be extra careful what you're stepping on and what you're not stepping on. Inspection of the feet, keeping it moisturized. There's a ton of products on the market. I tell my patients to put Vaseline. That's the best moisturizer on the market by far. But people think they have to spend more to get some of the fancier creams out there. So these are some of the things that you should do. Google, diabetic foot exam. It takes me literally 60 seconds to do. It's not hard. You can train yourself to do it. You can train your loved ones to help you out, and ask to get one done when you go to your family doctor for a checkup.
Okay. Dr. Cohen is one. It's interesting how things come back because the question, when you hear it, you'll find it interesting. Can you develop a treatment when the patient can be given a clot-busting drug via intravenous? So the question is, we've talked all about this elegant procedure of doing angioplasty for a heart attack. And the question is, and a very interesting one, could we just avoid doing the angioplasty and give them something intravenously to try and open the artery?
So everything old is new again. Right? Yeah, in fact, we already did that a long time ago. The history of heart attacks and what caused them and how to treat them is a really interesting history. 100 years ago, it was suspected that it was acute formation of a blood clot inside the artery that blocked the blood flow. And then, people thought they were getting much smarter than that and said, no, when we found those blood clots inside the artery at the time of an autopsy, they formed after death occurred. The cause of heart attack was spasm of the artery. The artery just got twitchy and spasm. That caused the heart attack. And that sent our thinking in what turned out to be the wrong direction for a couple of decades. It was only when another brave researcher in Seattle managed to bring several hundred patients with acute heart attacks immediately to the catheterization lab. They did an immediate angiogram. And they saw that about 90% of people who have a ST elevation on the ECG and acute chest pain have an acutely blocked coronary artery. And it can be quickly opened. And so that brought back this whole theory that it's thrombosis, clot, that causes the heart attack. So that prompted the use of clot-busting drugs, initially given right into the coronary artery through a catheter. But they realized that's not very practical because you can only give that in very few specialized places. So they developed the intravenous version. It can be given through a vein. It will reach the heart and help the clot dissolve. And lo and behold, that reduced the death rate from heart attacks quite substantially. The problem was these clot-busting drugs go everywhere, and they cause bleeding all over it. Some very serious bleeding, including bleeding in the head. And when you give it to someone who may not even actually have what you think they do as a true heart attack, then it can be a very bad situation. So as an alternative to that, we said, could we get people to the cath lab?
Your attention, please.
Do an
Your attention,
angioplasty.
please. May all units please retrieve an important message from your printer. Your attention.
I've never heard so many messages in an hour and a half. It's unbelievable how they.
He wants to be on.
Someone just is out there trying to say, let us interrupt as much as we can.
So we've kind of gone away from that treatment of using intra, but we still use them in communities that are further away. If you're going to do an immediate angioplasty, your target time is from the onset of the symptoms, the opening the artery, ideally 90 minutes, maybe 120 minutes. If you live very far away, small communities, that can't be done, even with helicopters and so on. So there the treatment is the intravenous clot-busting drugs with a fairly quick trip in the next 6 to 24 hours to a hospital that does have a cath lab where you can have an angiogram.
Which is, a lot of that research actually came right from Toronto, so we're proud of that particular finding of how to treat heart attack patients. So here's another interesting one. Maybe anyone can talk about, maybe you want to, about clogged arteries in the heart, but I think it applies probably in any vascular situation. When do the arteries first start becoming clogged? Is it when they're 20 years old, when they're 40, when they're 60, when they're 80? And is research being done in this area? And what you're talking about is early signs and pathogenesis of atherosclerosis. Do you want to take that one on?
Yeah, sure.
You're the one closest to the 20s. Yeah, Stephanie, actually.
Okay, so this is a very, very big topic. I don't think I'm exaggerating, billions of dollars that have been spent trying to study the underlying mechanisms of atherosclerotic disease, or clot and thrombus formation. What we do know is that there are a combination of reasons. The atherosclerotic or plaque forming process starts with an insult to the inside of the artery that starts to progress into plaque formation. And it's a very complex mechanism. We've mapped it out fairly accurately, I would say, but the reasons that this process starts are what we call multifactorial. So it could be genetics. Some people we know have a higher predisposition to developing clots or plaques. It could be, as a consequence of a Western diet. And it could be from lifestyle choices like smoking. And diabetes as well is also a known risk factor. So I don't think there's a very straightforward answer. I'm sure Dr. Poon's going to correct me shortly, but I think that as far as the peripheral vasculature in the legs and outside of the heart, it's still very much an ongoing research question.
I mean, we do see signs of early plaque formation even in the 20s in people on autopsy studies. Unfortunately, when accidents cause early death to people, that they actually already have signs of atherosclerosis when they look at their arteries, even in the 20s. So it's something that starts very early on, and in particularly certain types of genotypes that genetics that cause really high cholesterol can unfortunately bring it on even much earlier and more severe as well. So I think we have time for 2 more questions. I apologize, I can't do all of them. You have too many here. I've actually asked some of them that are the really, really hard ones. I didn't want to embarrass the panel here, so we're just trying to stick to the easier ones. I think this is very interesting because it reflects the way our treatment has changed only in the last year. I'm on Xarelto, which is an anticoagulant that we use for patients with blood thinner for atrial fibrillation. And the patient also has had heart attacks and stents. And after the second heart attack, that the patient was on Plavix and aspirin, and subsequently they stopped the Plavix and just left the patient on aspirin and Xarelto. The patient's asking, what should I be on in terms of blood thinner combination? And this is a very, very new question because we're finding out about this all the time. Do you want to give them a summary of this, Eric?
Summary in 4 hours?
Yeah.
So I'm not going to answer exactly what whoever asked the question, because that's as we said before, it's individualized. You need to discuss that with your own doctor and your cardiologist. But most of us agree on certain themes here, which are you're trying to prevent clot formation inside the stents that happen there. And we usually use what's called antiplatelet drugs, and that's what I mentioned, aspirin and Plavix, or aspirin. Brilinta is another one we use after a heart attack. And they work quite well, but they do carry a small risk of unwanted bleeding, including potentially serious bleeding. Then beside that, we have some people who have atrial fibrillation, this irregular heart rhythm that puts you at more risk for a stroke. And a very effective way of reducing the risk of stroke is to take what we call an anticoagulant, which traditionally was warfarin or Coumadin, but in recent years more convenient, newer drugs like Xarelto, which you see on TV all the time. But what if you have atrial fibrillation and you got a stent? Should we just combine all these different blood thinners to prevent all the different things? Well, it would work to prevent all the blood clots, but the problem is the risk of unwanted bleeding really starts to multiply. They're not, you compound all these risks. So because there's a lot of people with these combination of conditions, we've been very interested in what's the right balance here between preventing clots in the stent and preventing strokes versus not having too much bleeding. And we do have newer evidence. It's kind of been suspected for a while. It's been confirmed, at least in early studies, that probably you don't need 3 different drugs, so-called triple therapy. You don't need 2 antiplatelet drugs and 1 anticoagulant drug. There are various combinations. And increasingly these days, 1 anticoagulant like Xarelto, possibly at a slightly reduced dose, together with 1 antiplatelet drug like maybe aspirin or like Plavix. Sometimes you need all 3 for a short period of time, like a month or maybe even 3 months, and then down to 2, eventually down to 1. So it's an individualized question, but the theme has been recognizing that unwanted bleeding is a serious problem, cause major complications. Let's try and minimize the risk of that, even if we can eliminate the risk entirely.
Okay, that's fantastic. So last question goes to Dr. Poon, and this is a good one. If 60 beats per minute is ideal for longevity, why is aerobic exercise recommended since it significantly raises heart rate?
Aerobic exercise is recommended because it's not like you're doing aerobics all day 24/7, right? So it is good, and we do encourage you to get out there and exercise. However, if your heart rate is racing at 120 beats per minute constantly, you are going to have a higher mortality than if you had a nice, slow, steady heart rate. That's why elephants live longer than mice. There's a study that proved that, right? So the lower your heart rate is, the better you're going to be, especially if you have a weak heart. It only makes sense. If you have a weak heart, you really don't want your weak heart working that hard. So the less work you can give it by slowing your heart rate down, the better off you're going to be.
Okay, so with that, I want to thank our speakers and give them a round of applause for a fantastic event. And I just want to finish off with a few housekeeping details. I also want to thank the exhibitors outside the McLaughlin Auditorium. Please be sure to hand in your evaluation forms on the way out so that we can see how we did and maybe suggestions for future presentations. Please be sure also that you pick up your free parking voucher. And if you pick up 2, you can probably